Thank you, Joe, for the introduction, and thank you for the invitation as well to Turkey. My first time in Turkey. I'm enjoying it very much. So I'm going to also thank you to Faiza for your introduction to ketamine. So that's a load of things you don't have to hear from me. Okay, so I don't work on the molecular space. I work at the systems level using neuroimaging to try and understand drug action in the brain. And what I'm going to try and do today is take you through the effects of ketamine that we know about through brain imaging. And I'm going to focus pretty much mainly on MRI imaging. There are a few PET studies out there as well that answer very specific questions, but I'm going to try and operate at a functional level using MRI brain imaging. And it's not all of my work as well. So you already know a little bit about ketamine, thanks to the previous talk. That's a cartoon of the NMDA receptor, and ketamine goes into the open channel and sits into the PCP site. It's an uncompetitive NMDA antagonist. One of the mechanisms which is important is disinhibiting GABA and increasing glutamate release acutely as well. You've heard about its increasing of signaling through second messenger cascades, which fit with increasing plasticity, neuroplasticity. We have good evidence for dendrogenesis and possible synaptogenesis as well. Ketamine also has active metabolites. The main ones that seem to matter in depression are probably norketamine and 2R6R-hydroxynorketamine. There's a trial ongoing at the moment of 2R6R-hydroxynorketamine as an antidepressant itself. And there are some studies showing that norketamine levels actually do correlate with some of the imaging markers. It's very hard to do the same with ketamine levels because it is metabolized very quickly in the periphery. You get a rapid reduction of depression symptoms with ketamine, usually within hours. The earliest detected changes are 1 or 2 hours, but it peaks about 1 to 2 days. Oh, is it? Oh, is that better? Oh, yeah, look at that. Dear me, poor you. I'm very loud. So, there are 2 stereoisomers, S-ketamine and R-ketamine. S-ketamine is licensed as a treatment. Spravato is the drug by Janssen, and there are some early trials using R-ketamine suggesting it might also be effective. But most of the studies that I'll be showing you, in fact, all of the studies I'll be showing you, have used racemic ketamine as well, because that's the one that's been available all this time as a dissociative anesthetic. So one thing that's really interesting about ketamine is it has a time course of its effects, and I'll use this time course to guide us through the literature during my talk. It helps me understand it. I hope it also helps you understand it. So you have an acute phase of ketamine where it produces dissociative effects. There are some effects which some people call psychotomimetic, psychosis-like. We don't think it produces psychosis, but it increases the scores on questionnaires of symptoms of schizophrenia. That effect usually lasts for a number of minutes, maybe tens of minutes at most. And then you have what some people in the literature call the post-acute effect, which is a number of hours afterwards, where you will have the levels of ketamine in the blood will be very low, but the levels of the metabolites will be rising. And that is usually around 2 to 6 hours after the ketamine administration. And then you've got the delayed effects, where you almost certainly can't pick up any levels of ketamine or its metabolites, and that will be roughly 24 hours onwards, and that is actually when the antidepressant effects appear to peak as well. So I'll go through these different phases now. Oh, and Cho, I think that image might be from one of your colleagues. Good, there we go. That wasn't on purpose, it's just a good image. So first of all, what is the evidence? Oh yeah, I can use this. There we go. You can see that. First of all, what is the evidence that ketamine acutely increases glutamate? Well, there's quite a lot of evidence now, and this slide tries to summarize it all. It's not all the studies, but I think it makes all the necessary points. There's nice work in rodents using intracortical recording and MRS, showing increases in glutamate levels. There's this study that we did. James Stone, who's talking next door, myself and John Crystal did an MRS study to show increases in glutamate levels after an acute dose of ketamine. The correlation is with the positive subscale of the PANSS for psychotic-like symptoms. You can see here, this is in depression. You can see changes in glutamate and glutamine levels as well. And this study on the bottom is particularly interesting. It's using a relatively young technique called 13C MRS that enables us to pick up glutamate cycling. That was from John Crystal's group. And they're looking at that as a novel biomarker of ketamine's effects. But also this measure, in fact, it's a ratio measure of the glutamate cycling called EPC, is actually very sensitive in depression as well. There are some other studies here showing, again, changes in glutamate and GABA associated with ketamine administration. And this particular plot shows an association with the steady-state ketamine blood levels as well. How about the functional effects or functional MRI effects of ketamine during infusion? Again, there's quite a few studies, not loads, but quite a few. So I try to summarize them here. So if you look at something like reward processing, which is one area you may expect ketamine to affect, that might be directly through the ketamine action on the frontostriatal pathways, affecting dopamine release. You can see a suppression of reward-related activation in the brain. This here is a study that we did showing a relationship between the changes in anhedonia acutely and blood flow in the brain, showing these anterior areas might be associated with that. And ketamine acutely will increase anhedonia, even though in patients with depression, over the course of the day, it might reduce anhedonia. So this is an increase in anhedonia. There's some nice studies from Yale looking at how default mode activity changes with ketamine, and that might be related to changes in negative symptoms and working memory performance as well. This is a test-retest study we did showing reliable increases, particularly in frontal blood flow, which might be a really decent marker of ketamine's effects. And that goes back to the anesthetics literature that usually gives much higher doses of ketamine that also showed a similar effect as well. And what's quite nice is that the blood flow and the metabolism effects look quite similar, suggesting that at these lower doses, you don't get a breakdown of neurovascular coupling, which you do at higher doses, which means that ketamine is suitable for studying acutely using techniques like MRI. And then the plot on the right is something called PHMRI, where you try and track the time course of the changes in the bold signal in the scanner after an injection of ketamine. And usually the scan's about 10 minutes long. And you can see very nice increases in bold signal, peaking around the anterior or paracingulate gyrus as well. And there's a nice study by Downey, which is looking at a similar methodology, but in patients with depression, showing increases in subgenual singular activity, which weakly correlate with the outcomes on depression scales. And also there's some other studies, again, only one other study, showing increases in bold, and they found that the insular and the postcentral gyrus changes also correlated with the later changes in depression symptoms. So these are the different techniques people use to measure acute effects of ketamine. Oops. Oh yeah. So just a little bit more, I was just going to say, I've got this wrong way around, sorry, but a little bit more about the PHMRI technique. So the technique behind these maps is where you inject, I'll show you with nicotine, you inject nicotine here and you can see the plasma levels change and you can look at that in the brain images and track it. You can't do the same with ketamine because the pharmacokinetics don't allow that, but what you can do is develop a model from pilot data. You can input that as an input function into your imaging data and get your PHMRI response. And that's this technique here, that people use. I thought I'd put the method up because it's not a technique that's used much anymore. And it's nice because it's translational. You can do it in rodent MRI as well as human MRI. So using that technique, PHMRI, you also have the power to add in blocking agents as well. So this is a few studies, one of which was ours, one in rodents and 2 in humans, trying to block the effects of ketamine on BOLD with lamotrigine. The theory being that lamotrigine will be reducing the glutamate release. So it's another validation that you've got a glutamatergic effect here through increased glutamate levels extracellularly. And in the rodents, which you can see nicely here with the blue and the red bars, the blue is the ketamine response, and the red is the pre-dosed response with lamotrigine. You can see a big attenuation of the ketamine response. And this is a study from Bill Deakin in Manchester. That's the ketamine response. That's pre-dosed with lamotrigine. And this is our own data. This is the ketamine response, and that's pre-dosed with lamotrigine as well. So you can see very nice suppression of the effect across multiple studies. So all these studies tell us that there is a strong acute effect of ketamine. Some of the measures, particularly the glutamatergic ones, might relate to the psychotomimetic symptoms. There is weak prediction of some of the antidepressant effects you get later, and there are changes across multiple domains using fMRI, PHMRI, and perfusion imaging. So let's move to the post-acute phase. Now, what happens in the post-acute phase is you start to get symptom reduction as well. So, and there are a few early studies looking at the post-acute phase, and they were using PET imaging, and I highlight in particular the 2 studies by Neil Lally, who showed increases in the dorsal anterior cingulate metabolism with FDG PET. And some of these changes actually correlated with the later outcomes in terms of depression symptoms as well. One of the challenges with doing imaging in patients is that you will get a change in brain imaging signals, one would hope, but you'll also get a change in symptoms. And it's kind of interesting when they correlate, even though some of these studies might be a bit underpowered. But what you don't know is where the cause and effect lie. You don't know if the changes in the brain are leading to the changes in the symptoms. You can deal with that sometimes by looking at early changes in the brain and later changes in symptoms, which is what I've shown you already. But you might also want to look at the changes which accompany the symptom change, at 2 hours and 24 hours after ketamine. But then, of course, that's also a confound because you don't know whether the imaging changes are secondary to the symptom changes. And what you're looking at reflects the different state of the patient rather than the treatment effect. I hope that's clear. So it's about the cause and effect direction. So we did a study looking at patients who were remitted from depression where we expected a ketamine effect, but we did not expect symptom change. It didn't have symptoms as well. So we could at least have one study which didn't have this confound of symptom change in parallel with imaging changes. And I'm just showing you a couple of results from those studies. This bit is unpublished. So this is resting state connectivity, which I'll come to later. You'll see it's been used a lot for the delayed effects. And you can see that the sort of overall functional connectivity, which we focused initially on the ventral striatum, because we've seen some nice effects of reward processing tasks in the ventral striatum. And you can see on this plot here that every participant who took part of the study in the crossover design with racemic ketamine, you can see, not everyone, sorry, but on average, the participants showed an increase in ventrostriatal connectivity. And this map shows you the areas of increased connectivity with the ventral striatum as well, which includes areas like the iris. You can split the brain up into networks, which I heard about the talk meeting as well. And you don't need to read this, but basically this is all the different canonical networks that you can pull out of ICA-type analyses. And these are the effects of placebo and ketamine on each network. This map here shows the only differences between placebo and ketamine at this post-acute stage, 2 hours later, showing some changes in areas such as the hippocampus in connection with the central executive network. So the central-negative network, the DLPFC, for example, comes up a lot in the ketamine effects, which suggests that there might be some top-down influence of higher-level cognitive processing in mediating the treatment effects. Oops, wrong one. Here we go. We also, in the same study, did a reward task. You can see our first analysis was looking at connectivity of the ventral striatum. And I won't take too long on this because it's a paper published by a student at the time, Vasilia. And we use the MID task, which is familiar to all imagers, where you have to just respond very quickly to a white square on the screen. And that square is sometimes preceded by a reward predicting cue. And what you can look at with the imaging, which is very neat, is this period of time when there's no behavior occurring and you're anticipating the potential for reward. You can also image the outcome as well. It's a bit of a busy graph, but overall, we showed the effect that ketamine boosted activity during anticipation of reward, and it also boosted activity during the receipt of reward. Some of these changes were more restricted to different parts of the striatum, but the overall effect was also significant. And you can see here that on the feedback of low reward trials, actually the increase was in the entire reward processing network. And it brought up activity from a low reward trials to what you'd expect in a higher reward trials. So we think it made low reward stimuli a bit like high reward stimuli. And this, I highlight this effect here because this effect correlated with one of the metabolites, which is 2R6R hydroxynorketamine, which is, in some animal studies, is predicted to be one of the main mediators of ketamine's antidepressant effects. Okay, now I'm going to move on to the later delayed effects. Okay. And there are many studies in this area, so I'm going to summarize them in a different way. I won't go through individual studies. You'll be glad to know. So there's spectroscopy studies looking at MRS. Effectively, there are no changes in MRS, glutamate, and GABA levels about 24 hours to a few weeks after the ketamine administration, on average across the studies. There's some PET ligand binding studies using things like mGlu5 receptor ligands, which indicate, again, possible changes in glutamate release acutely, but the studies haven't been done, delayed effects, or at least not I'm aware of. And there's FDG studies as well that look at changes over time. There's also studies looking, a small number of studies looking at structure using diffusion and T1 weighted images, which seem to be showing emerging changes, which are interesting and worth following up. But I'll focus here on the fMRI changes to keep in line with the previous sections of the talk. And there are 3 nice reviews out there looking at changes, particularly in connectivity. There's, they've gone. There's this review here, which we did, looking at all the resting state connectivity studies. There's this study here, which looks at which tries to separate them out into their intrinsic connectivity networks, the results. And there's this study again, also from our group, trying to summarize all the effects of the anterior cingulate connectivity changes. I'll give you a brief summary of each of those because they're all published, and if you want to follow up, you can get them, or if you can't, you can just email me. So using global brain connectivity, there are increases on average with ketamine, mostly in patients, but this is one of the few studies where there's an attempted replication, and it wasn't replicated. So it's worth bearing in mind for all the literature I've shown you that there are very few replications. Some of the acute ketamine effects have replications, and those regions come up again and again, but these delayed effects, there's very few replications. But you also see increased striatal connectivity. You see changes in hippocampal and amygdala connectivity. And if you have a look at the longer term effects, you can see persistent effects going out to a number of weeks now. An example is DMN insular connectivity changing in the Evans study, and that being persistent. The review about the anterior cingulate connectivity, we split the cingulate up I don't have the detailed map of the split up of the cingulate, but generally you can see on the right-hand side, you've got the subgenual cingulate, which we split into two areas for the analysis, and the pregenual cingulate. The pregenual cingulate connectivity tends to actually predict the ketamine response, whereas a subgenual cingulate, most of the studies are describing the ketamine response. We tried to look across all the studies, and we think that a lot of the results fit in with these two networks, which might be involved in things like emotional pain and rumination. So you've got the insular thalamic anterior cingulate network, and you've got a bit more like a default mode network with the thalamus as well. So that's our summary of that literature, and you can read the paper if you want to see how we got to these conclusions. And then the third study, which isn't from our group, is a bit more complex to summarize because the results were all over the place. So what I've tried to do is give you a sense of which networks are more consistently involved across these studies. So these are my calculations, they're not from the paper. And these are the networks they use, which are quite classical intrinsic cognitive networks, like default mode network, affective network, reward network, central executive salience, somatomotor, and the autonomic network as well. And you can see that it's the DMN, the affective network, the central executive network, salience network, and somatomotor network. They're the ones that come out most across all of these studies. So it's not to mean that effects of the reward network are not important, because there's a lot of heterogeneity in these studies, but it does give you a sense of where the majority of the results seem to be sitting and which networks may be guiding the majority of the effects. Some of these studies have correlations with symptoms and some don't. Some are very small and some are much bigger. So it gives you a sense of where to look, but you need to dig into the individual studies to look at quality. There's also some task-based imaging, but I won't focus on that today. But I'll just summarize it here for you in case you're particularly interested in one of these tasks. So there's lots of challenges and limitations to these studies. This is the majority of my conclusion. So particularly for those studies that look at the delayed effects of ketamine, the sample sizes range from about 10 to 55. There might be one study with more than 60 in, I can't remember, but you get the range of N's. So some studies are very low quality in terms of N and power, and some studies are getting into much better quality for power. So a lot of the variation across literature might be stochastic, it might not be real. There's mixed inclusion criteria. There's a variety of definitions of what treatment-resistant depression is, which makes up the majority of the people in these studies. Sometimes people are withdrawn, sometimes they're not, from their existing antipsychotics. There are different administration protocols. I'm not sure I've seen much that tells me that's very important, but it's definitely worth bearing in mind. There are different connectivity methods across the studies, and there are different focuses of regions. A lot of the acute studies were done because of the psychotomimetic effects, and they focus on some networks, whereas a lot of the delayed effects are looking at depression, and they focus on other networks as well, apart from, and there are a couple of studies that try to look across all networks as well. We do have some understanding of the neurobiology of depression, of course, but really, if you look across the literature, there aren't that many studies in unmedicated patients. So we don't have a clear understanding. Vasilia tried to summarize those in her review as well, but there may be different subtypes or biotypes of depression in amongst all these studies. So there might be a variety of pathologies that exist, and so that might explain some of the heterogeneity. So what we really need to do now is start data sharing and doing larger studies so we can understand the effects of ketamine longer term in much larger groups that are powered enough for correlations. They're powered enough so you can look at some of the heterogeneous factors as well, and we're just starting to do that. So people to thank that are behind some of the studies that I've presented as well, and we've got some great collaborators, and the people on the right were involved in some of the earlier studies that aren't in the group anymore. I'll leave with this image at the end to tell you that, to hopefully show you my summary of the different time points at which you need to understand ketamine effects and how they might differ. Thank you very much.